guys, today I'm going to start with presenting just an overview of things so that we are all on the same page. I have no financial disclosures, and then I do have a land acknowledgement from where UCSF sits to the Ramay people. And so this is the same slide and same agreement that I had from Grand Rounds, that there are a lot of nuances in this topic, in this area. There's a lot of research that's coming out. There's a lot of, expert consensus and expert opinion. There's not a lot of right answers. And so please ask your questions, please comment, please share your experiences with your patients, and we can all learn together. As you all know, I think I saw one of the questions initially about what waiver training is necessary to prescribe Bupe. There is no waiver training that's required to prescribe Bupe for any indication. So everybody can prescribe Bupe regardless whether if it's for treating pain or whether it's for treating opioid use disorder or treating both, which is most often what happens in palliative care. So as Grant pointed out, this is the rough roadmap. Today, we're going to focus on getting the basic building blocks down so that in the future sessions, we can actually build on some of the cases and introduce some of the challenges that you'll probably see in clinic. Today, we're going to start with some pharmacology, formulations, review all that, make sure we're on the same page, and then start to talk about how you might approach somebody who's on buprenorphine and manage things that come up like acute pain, peri-procedural pain, changes in pain. And then in the subsequent session, in the next session, which is the second part of this building blocks piece, is we'll talk about some different initiation strategies and then really do a lot more practice and discussion about rotating between Bupe products, between Bupe formulations, between buprenorphine and full opioid agonists, a lot of the more nuanced kind of specialty pain procedures. And then in March and April, this is really TBD for whatever topics come up as you're putting this into practice and reviewing a lot of cases, both that I have to share and that you guys have to share as well. So everyone loves a little kind of self-check first thing in the morning, but I'm going to invite you all to put this into chat if you want to, or just choose an answer for yourself and see how it matches up. So as a review, buprenorphine acts at the mu-opioid receptor. It is a either full or partial or antagonist with a strong or weak binding affinity. So I'll let you think about that for a couple of moments for yourself. Okay, and then let's get into some Bupe pharmacology. So as a very general overview, you may know a lot of this already. Buprenorphine is a partial mu-opioid receptor agonist with a strong binding affinity, and it really has these three properties that are unique from all the other opioids that we use on a regular basis. So just to orient you quickly, for this chart, the x-axis is the dose, so increasing opioids as you move further out, and then the y-axis are the mu-opioid effects. So this includes things like respiratory depression, includes nausea, it includes constipation, it includes also things like euphoria and, of course, analgesia. And so when we think about most of the opioids that we use, like methadone, hydromorphone, fentanyl, heroin, those opioids fall along the green line, which is the higher the dose you get, or the more that someone takes, the more of the total mu-opioid effect that they're going to get, whether that's analgesia or whether that's respiratory sedation, nausea or constipation, or cognitive slowing, cognitive sedation. And then the red line is the antagonist, like naloxone. And buprenorphine falls into this middle line, and you'll see that it kind of curves. It reaches this threshold as you go up on the dose where the mu-opioid effect continues to rise, and then it reaches the ceiling where it then flattens out. And so this is what they call the ceiling effect in buprenorphine, and this is why it's a partial agonist. So it means that even if you give more and more doses of buprenorphine, you will not get more and more mu-opioid receptor effects as you go up into the higher doses. And this is what we can really take advantage of in terms of buprenorphine being safer with regards to things like respiratory depression or euphoria, and kind of reducing its addictive potential. It does not mean that being a partial agonist, that it's a partial analgesic. And so that's one misconception of buprenorphine that is held by both clinicians and patients alike. That's important to dispel, and we'll talk about that a little bit more when we get into the pain piece of it. The second important quality is that buprenorphine has a really high binding out affinity to the mu-opioid receptor. So if you had a system where you had both buprenorphine and you had another full agonist like oxycodone, the buprenorphine will outcompete the oxycodone. So it'll, sit on the receptors at a greater frequency than the oxycodone will. And if oxycodone is actually in the system, buprenorphine is strong enough to where it actually displaces the oxycodone. And so it outcompetes whatever other opioids might be there. And then once it sits there, it stays there for quite a while. So the pharmacologic half-life of buprenorphine is 24 to 36 hours. And this long-acting stability is what helps it with managing opioid use disorder. Just like methadone has a really long half-life, helps prevent kind of withdrawal and cravings during that time. But when you put this all together, this is what most people know about buprenorphine, both in terms of patients and clinicians, which is that there is the potential for precipitated withdrawal if you add buprenorphine to a system that already has full agonist. So again, if you're somebody who's regularly taking any full opioid agonist or FOA, such as regularly taking oxycodone or regularly using heroin, you're going to have mu-opioid effects that are consistently this high. And if you add buprenorphine to the system, the buprenorphine is going to displace what's there and then exert its effect, which is going to be a notch lower. And this transition, this delta, or this total kind of reduction in opioid effect is going to feel like withdrawal. And there are ways to get around this. So for a long time, this is what was prohibitive for pain management or say palliative care, and really using buprenorphine for patients who have, say, cancer-related pain and need to stay on some full opioid agonist to manage the pain. But there are new techniques that we'll talk about to circumvent that and to keep patients with some level of acceptable analgesia while you're rotating them from the full agonist to the buprenorphine. So there's a initiation strategy where you can have both in the system at the same time, the Bupe and the FOA, without causing precipitated withdrawal. This chart is just one study that shows kind of the reduced risk or the reduced effect that buprenorphine has on respiratory sedation. So BBF is the buccal film or Belbua, and they gave different doses from 300 to 900 in the yellow graph, and it shows that there's not really significant reduction in the respiratory drive compared to when they gave like 30 milligrams of oxycodone, which is in the blue. So because Bupe is this partial opioid agonist, I think about it kind of like the toddler headphones, like I mentioned. So, the toddler headphones have this safety mechanism where you can continue turning up the dials, but the sound that gets transmitted is capped at a safer level for protecting kids' ears. Again, one of the important misperceptions to dispel is that because it's a partial agonist does not mean that it's a partial analgesic. It's actually a safer opioid analgesic against accidental overdose because of the lower effect on respiratory depression. Now, buprenorphine also has these unique capabilities compared to all the other opioids that we use, which is it is a kappa opioid receptor antagonist. And what this means is that it blocks central sensitizations or reduces hyperalgesia, or that hypersensitivity to pain that comes with being exposed to opioids over long term. And then the kind of subjective corollary to that is that over time, when people are exposed to opioids, they can develop this hyperkatifia, which is a heightened sensitivity to negative emotions. So dysphoria, anxiety, et cetera, that comes with long-term opioid use. And the kappa opioid receptor antagonism effect actually reduces your risk of developing that, and may act as an antidepressant on top of that. And so some patients do feel an improvement in mood. They feel a lift. Some feel like a little bit of extra energy. Perhaps it's less sedation. Perhaps it's this kappa opioid antagonist effect. But all of this put together, as well as the reduction in cravings compared to being on full agonist opioids, makes buprenorphine a really unique opioid in our toolbox. And then it also has this like ORL1 agonist binding, which is thought to reduce spinal reward, reduce spinal anesthesia, and essentially, again, act in reducing that risk of central sensitization with long-term opioid exposure. So I mentioned that buprenorphine has a long pharmacologic half-life, just like methadone. And some people, like for opioid use disorder, only need to take it every other day, or they might just take it once a day and feel stable during that time. But just like methadone, it has a shorter analgesic half-life. So the analgesic half-life is really 4 to 8 hours, which means that for pain relief, buprenorphine has, or using buprenorphine in a split dose manner, like 2 or 3 times a day, really helps to take advantage of that analgesic window. The time to peak action, just for you to be aware of, is when you take a sublingual film or tablet, about an hour for it to peak. So if you're doing a sedation check on somebody, it's pretty safe to check on them like in an hour and a half to see kind of what the max effect is. The transdermal patch takes 3 to 4 days to reach its maximal effect, so like 90% of its steady state. So you titrate the transdermal patch every 3 to 4 days. We'll talk more about that. Bupe is highly lipophilic, which really opens up the door to a lot of different formulations and a lot of different routes. It also means that it's not very effective if you take it orally. I do have a patient who's taking like 2 milligrams of sublingual buprenorphine 3 times a day, and it seemed to work really well for her kind of lingering chronic cancer pain. And then her pain got worse, and I was asking her, you know, how she's taking it, and she said she was swallowing it. And so I told her, like, it actually doesn't really work that well when you swallow it. Try just putting it under your tongue and letting it dissolve. But the high lipophilic absorption means that, you know, the patches exist so it can get absorbed through the skin like fentanyl. It gets absorbed sublingually and buccally, which means that if you have patients who are NPO, this is a really great alternative if somebody needs a long-acting opioid. And then lastly, you don't need to adjust buprenorphine for anyone on dialysis or anyone with renal failure. They do recommend avoiding it in decompensated liver failure, so Child-Pugh class C, or anyone with active decompensated liver failure. It does not mean that you can't use it, though, in somebody with liver failure or with liver cancer. For those patients, I would use the buprenorphine MATA product, so not the buprenorphine naloxone combination, regardless of the indication, because it's thought that the naloxone is not metabolized as well, and so people might feel a little bit more of the withdrawal effect. So you can use buprenorphine in the compensated kind of limited liver function. Okay, and you've seen the slide before. So for all of these different reasons, buprenorphine becomes a great first-line opioid, and the VA, as well as the CDC, have started writing that kind of as guidelines. At the VA, they actually recommend thinking about buprenorphine as a first-line opioid when patients need opioid analgesic. So it's a Schedule III opioid. It's way safer than Tramadol. And so if you feel like, I don't know really who uses Tramadol that much, but if you want to, you know, sometimes I think people are like, oh, it's a little bit safer, whatever. Try using the buprenorphine instead. So you can use it in these two pools of patients that I usually think about. You can use buprenorphine as a harm reduction tool because it has less of that respiratory suppression effect. And actually, if it's in the system and somebody then uses, for instance, non-pharmaceutical fentanyl, it actually is somewhat protective, right? Because it's sitting on the receptors, it binds really strongly, it'll prevent some of the other opioid from exerting its effect and can reduce your risk of accidental overdose. So I would always consider it in somebody with active opioid use disorder, anyone who's using other substances like alcohol or benzos, non-prescribed, prescribed, just because it has that less synergistic reducing respiratory effect. You can use it in people with a mild opioid use disorder or this complex persistent dependence, where when they come off of opioids or when they taper off of opioids, they actually get less functional. They get more dysphoric, they get more pain, they have worse sleep, they have anxiety. You can use buprenorphine as a safer alternative for long-term opioid therapy. And then certainly for anyone where there's concern selling or sharing medications, I mean, if you decide to prescribe opioids at all, this would be the safer one, just in that if this is what they put out into the community, you know, you're introducing a safer supply of a safer medication. The other pool of patients who I think about are folks who would benefit from this improved side effect profile, or folks who are very sensitive to the full agonist side effects. So people who are cognitively frail, or I have patients who are working or really value their mental alertness, I will often try buprenorphine first to see if we can reach that balance between pain control and, you know, cognitive function. It is safer for elderly folks and then for really young folks. So I think a lot about like adolescents or young adults who are getting exposed to opioids. Again, like this is going to be the safer opioid over longer terms during their treatment. If people are sensitive to constipation, to mood effects, if they are, if you're already concerned about some degree of hyperalgesia, rotating to buprenorphine might be more beneficial for that patient. Okay. So we're just going to do a couple of self-check questions. Suboxone contains both naloxone and buprenorphine. Suboxone is the brand name for the combination medication. And we use naloxone to reverse opioid overdose. So does this mean that the patient goes into a little bit of withdrawal every time they take some Suboxone? And I wonder, let's see. I wonder if anyone wants to share their answer. Or you could put it in the chat.
I'm happy to jump in. No, like, as long as you're taking it sublingually and not injecting or snorting it, the naloxone will be active, so it won't induce any withdrawal.
Great, thanks, Carter. Yeah, that's exactly right. So the naloxone component is really only active if somebody is using it differently from prescribed. So really, it's a deterrent against injection use. And when you're taking the Suboxone sublingually, the buprenorphine is the part that's getting absorbed. Naloxone has very, very poor absorption, and so it really is not active. Although I will say that, you know, there is a little bit maybe of naloxone absorption when people take it orally. It's pretty negligible, but for patients whom I've had on this combination product, if you do a urine tox, many of them will have naloxone be positive. And so it's just something to be aware about. If I have somebody on the combination product and I'm not really getting ahead of their pain control, I will then sometimes, in the right circumstance, switch to just the mono product and see if we get a little bit extra benefit with that. And while the naloxone is there to prevent or to deter misuse, I will also share that the mono product is a lot less expensive than the combination product. And so for like the opioid treatment program here at the General, so at the SFGH, methadone and buprenorphine treatment program. Since they have to purchase their own supply in order to dispense it to their patients who show up for daily dosing, they actually purchase the mono product, because at the end of the day, people are going to do what they're going to do, and they're going to treat what they're going to treat however they can. So, yeah. All right. So if someone is taking full agonist opioids without telling me, and I give buprenorphine, I may precipitate withdrawal in them. Yes or no? Yes, great. That's true. That's exactly what we said. So if someone is at a full agonist kind of sensation and you introduce buprenorphine, they're going to drop to a partial agonist, and that delta is going to feel like precipitated withdrawal. On the other hand, if someone is taking buprenorphine and they don't tell me, and then I prescribe a full agonist like morphine, I will precipitate withdrawal. Yes or no? Great. Thanks, Sandy and Jocelyn. So no, exactly. So if somebody, is taking buprenorphine and they're at some level of opioid agonist effect, partial opioid agonist effect, and you add another FOA on top, it'll just elevate or do nothing if it can't bind to the mu-opioid receptor because the buprenorphine is already there. Great.
Can I jump in with a quick question?
Absolutely.
For that last slide, that first question about adding buprenorphine if someone's taking a full agonist, does it depend at all on the dose of buprenorphine, or is that not a good time for that question?
No, I mean, that's a great question. So it does depend on the dose of the buprenorphine, and that you're getting at the kind of low dose initiation or microdosing, where there is a dose of buprenorphine that is small enough that you will not precipitate withdrawal. But you have to be usually pretty conscientious about that dose. It's somewhat of a manufactured dose. Like, it's not the natural, this buprenorphine sublingual film or tablet comes in 2 milligrams at the lowest dose, and that is enough to precipitate withdrawal. But there are other ways to get around that. So
thanks. That's helpful.
Great. Yes, please jump in with questions. So here's one for you guys, though. Like, can you overdose on buprenorphine? Have any brave volunteers? That's okay. I won't put you on the spot. So at the end of the day, buprenorphine is not this panacea. It's still an opioid. There is still risk for accidental overdose. And in fact, it does happen. And what you'll see in the literature when there is accidental overdose involving buprenorphine, it usually involves co-ingestion of a benzodiazepine or another kind of non-opioid sedative. With what's out there today in the community as far as drug supply, there's a lot of non-pharmaceutical fentanyl, and then there are things even beyond fentanyl that are non-pharmaceutical and even stronger than fentanyl. And so in any combination of those things, like, yes, like, people can theoretically, or they can overdose on buprenorphine. So I just wanted to make sure I say that. And it's still safer than all of the other opioid agonists that we prescribe to. Okay, so if someone is on buprenorphine and in acute pain, adding a full agonist opioid will not be effective unless the buprenorphine is stopped. Great, thanks, Grant. Right, no, so you can treat someone who is taking buprenorphine and has pain with a number of different strategies, which we'll get to today. All right, that's the last of that. So we got through that. Here is a case of this is actually the case from that I presented before. So it's a 65-year-old man with metastatic prostate cancer, with mets to the spine, who has stable disease. He has low back pain that's been worsening for the last 6 months, shooting down his legs, keeps him up at night. He's tried a bunch of different pharmacologic and non-pharmacologic treatment, not including opioids. His oncologist had started Tramadol 25 milligrams as needed, but the patient stopped taking this because one dose caused severe constipation. And so he's seeing you and asking, what else is there? Should I keep taking the Tramadol? Should I continue with just my over-the-counters? You do decide to offer him buprenorphine because you're like, you have constipation, you have a stable disease, this is pain that's impacting your daily function. We could try an opioid. What dose of buprenorphine might you start him out on? So we have a Bupe sublingual at 4 milligrams daily. We have the Bupe buccal. I didn't even put a dose there. And then we have different transdermal patches. So what I'm going to ask here is that maybe everybody choose an answer and then type that into the chat without pressing enter, and then we can all press enter and see what we get. Oh, great. So Jocelyn, Sandy, say C. Hey, Carrie, maybe some sublingual Bupe. Let's take more Bupe transdermal. Okay. And then maybe everyone can hit enter so we can just see the representative votes for which Bupe formulation we would start. Great. Okay. A whole smattering of things. Perfect. So let's talk a little bit more about the different, that's the best answer, Shereen, about the different formulations and when you might choose one over the other. So there's multiple buprenorphine formulations, and this is also why it gets a little bit confusing at first. It's kind of like Epic, like there's a lot of ways to tailor this and it becomes overwhelming. At the same time, on the other hand, it can be really helpful when you're trying to fine tune which product you're going to use. So for the most part, I think about all these formulations in 2 buckets. One that's FDA approved for pain, and then one that's FDA approved for the treatment of opioid use disorder. And this used to matter more when you needed an X waiver to prescribe anything in that right column for the treatment of OUD. At this point, it doesn't matter. Anyone can prescribe anything for any indication. The only pushback you'll get is likely from insurance for sometimes saying like you're prescribing something that's approved for OUD for pain or for not a person without OUD, like tell me more about this. And tell me more about this is probably a nice way that they would ask you to do that. So in the pain section, you have the transdermal patch, you have the buccal film, and then you have IV formulations, and then you can use the sublingual kind of off-label for pain. The ones that are highlighted in red are the formulations and the products that we're going to focus the most on because those are the most common ones. I understand from Grant that you have Buprenex or the IV buprenorphine like on formulary inpatient. I'll say that we don't actually use it all that often inpatient, and what I see is it maybe gets used the most by acute or chronic pain services if they use it at all, or in places where they don't have other formulations on formulary, like where they don't have a transdermal patch or the buccal film on formulary. Some people have devised ways to initiate buprenorphine on someone who's on full agonist using the IV formulation. So then the opioid use disorder formulations, Suboxone and Subutex, those are the sublingual combination buprenorphine naloxone products or the monoproduct buprenorphine. And then there's some longer acting injectables like Sublocade, Brixadi, Probufene, which are really at this point mostly used in the OUD world, although there is increasing interest in, if you do have someone with chronic pain or somebody with some opioid misuse and you needed something that was less kind of flexible in terms of self-titrating. Like, could you just give somebody a 1-month injection of buprenorphine and say, like, that's your dose, like you're set, instead of writing a prescription? So looking at the transdermal patch, which we'll talk a lot about, and which is one of the most useful formulations of buprenorphine, it is a 7-day patch. So you put it on and you change it every 7 days. It comes in these doses, so 5 to 20, and it maxes out at 20 micrograms per hour in the United States. And you might see that there are some kind of written like warnings about QTC prolongation in using the fentanyl transdermal patch. And what the research shows is that, yes, while they've compared buprenorphine against methadone for patients, for instance, in QT prolongation, the buprenorphine can increase the QTC, but it never, in none of the patients that they studied, did it translate into a clinical meaning of clinically meaningful event. So nobody had torsades. They might have had, their number, the QTC number go up with unclear significance. And I'll have to say, like, in my practice and all the transdermal patches I've used, I haven't really seen a significant increase in QTC, and it's not something that I monitor with any regularity the way that I do with methadone. But given this, some people are then kind of feel hesitant to use the Butrans patch or the Bupe transdermal patch because of that concern. And what I'll say is that in Europe, they have transdermal patches that go up to like 80 micrograms per hour. So it's 4 times what is available here in the US, with the same data they've interpreted as, being more safe than risky. And so the FDA has approved up to a max of 20 micrograms per hour. Sometimes in some patients who, can't tolerate any full opioid agonists and can't tolerate, for some reason, any other formulation except for transdermal, we have been able to get insurance to cover like up to 2 patches. So some patients I have had on 40 micrograms an hour, and I'm not worried about their safety at all with the QTC. The only instances where I might, just check a QTC is if they happen to be on antifungals and other things that, also prolong the QTC, just as you would with methadone. The transdermal patch, so once you put it on, there is this ramp up period, just like with the fentanyl patch. And so I'll tell patients, it takes really 3 to 4 days before you'll see the full effect. So if you put it on today and I talk to you tomorrow and you're like, I don't feel any different, I wouldn't be worried. That's exactly what I'm expecting. And then in 4 days, that's when you can actually titrate up again to the next step. Or that's when you can assess a little better what the effect is of that transdermal patch. I put dermatitis there because one of the kind of most common side effects that I run into with the Butrans patch is a dermatitis. And I think I've heard that from colleagues as well who use buprenorphine. I'm not really quite sure what's from. Some people think that it's because the adhesive or the matrix on the Butrans patch is just a lot worse than, say, what's on the fentanyl patch, or different from what they use in Europe, where they can go a lot higher with this dose. Buprenorphine also tends to be more acidic of a substance. And so some people think that maybe, I think that, it might just be irritating for the skin. But if that happens to you, if you have a patient who's trying the patch and it's working pretty well, but they develop dermatitis at some point, the first step is really, to try rotating spots, try it again. Oftentimes, people will add a topical steroid. So wherever you're going to put the patch on, just put on a steroid cream like hydrocortisone, let it sit for a little bit, and then you could put the buprenorphine patch on top. And sometimes that's enough. I've had a pharmacist in Ohio State say that, if people have Flonase at home, they could, spray some Flonase there, use whatever they have to get around it. This table on the bottom is from the manufacturer. So it's from Butrans as far as what their recommendation is for how to choose which buprenorphine patch you initiate. And so I will say that I used to, and I still do, refer people to this chart when they're starting out, just because it was put out by the pharmaceutical company. They've done a lot of work to ensure that this is the best recommendation they have for their product. And knowing that it's from the pharmaceutical company, it's a little bit more conservative than what folks have found to be effective in real life. So for opioid naive patients, definitely I would start at 5 micrograms per hour, kind of like the patient.
Where's the volume?
Kind of like the patient in that scenario. For somebody who's relatively opioid naive, maybe has tried like oxycodone, like 5 milligrams once or twice a day, but has some side effects from that. 5 micrograms per hour is where I'd start, just as a test for tolerability. And then at the end of the day, I find that most people don't really feel 5 micrograms per hour. It's more just a test to make sure that there's no other issues, excuse me, in tolerating buprenorphine. And so, you know, to start 10 micrograms an hour, which you can do, or 20 micrograms an hour, which you can do regardless of what the patient might be taking full agonist wise, you might follow what these recommendations are. I'll say like offhand in a hand wavy kind of guidance, which is why it's not written down. Like some people feel like the OME equivalence between a transdermal patch formulation and full agonist is like 1 microgram per hour to 2 OME. So a 5 micrograms per hour patch might deliver something like 10 OMEs of opioid effect for someone. And that is not, I wouldn't use that kind of equianalgesic, I wouldn't use that as an equianalgesic conversion ratio. I would just kind of use it as a guide in your head if you're not quite sure where to start. Buprenorphine patch is a great way to get familiar with buprenorphine. It is the safest of the safe opioids, right? So it has such a slow onset. It's such a low dose, right? You're starting at like 10 OMEs really. It's kind of like the gateway to buprenorphine. It's in micrograms per hour. So just note that for all of the pain medication formulations, they're in micrograms rather than milligrams. Again, because of the different opioid tolerance in the patients that they're kind of targeting. Are there any questions about the Butrans patch? It will tell you on the package that you're not supposed to cut it. I have a patient who told me that they've cut down a 10 microgram per hour patch into quarters. And so they're giving their dad 2.5 micrograms an hour. And, you know, it's okay. Okay. So the buccal film, the Belbua formulation is also for chronic pain, because again, you'll see it comes in micrograms. This has a greater dosing range. So it starts at something like 75 micrograms, which is what they recommend for folks who are relatively opioid naive. And then you can titrate it up to 900 micrograms. And this is generally taken like twice a day. So BID dosing, although people can take it once a day and some people do take it as needed. It takes 30 minutes to dissolve. You kind of put it up where your cheek is, which has a lot of fat that helps in the absorption of the buprenorphine. It takes a couple of hours to get to max steady state. There is a Belbua, the pharmaceutical company, does have a dosing app. And so if you wanted it kind of at your fingertips, you could download the app and then they'll help you decide like what your patient is taking now and what dose of Belbua they would recommend starting. At 900 micrograms twice a day, I think in practice, folks feel like you can't really get more than like 150, 180, 150 to 200 OME worth of opioid effect for pain. Certainly you would not start someone at 900 micrograms twice a day. You'd start them in this middle range and then titrate up. And that's what the Belbua company recommends. Also like every 3 to 4 day up titration. Belbua isn't used as much from what I've seen, unless it's on the inpatient formulary, just because it's really, really expensive.
Hey, Janet, we had a couple of questions back about the transdermal patch.
Oh, yeah.
One was just, are there any particular anatomic locations that are optimal for putting the transdermal patch on?
They recommend like the arms and legs, just like the fentanyl transdermal patch, and that you rotate spots every site, every time.
Okay. And then just a clarifying question, just again, so is it okay to cut the patches, or is this a gray area?
Technically not okay to cut it. The official party line is like, you shouldn't cut the patches. That said, people do cut the patches, and I have had patients cut the patches to get the effective dose that they need.
And just for folks on the line too, while we're speaking of Belbuca, our inpatient pharmacy does not stock Belbuca. So we've just got the sublingual tablets and the transdermal patches and the IV buprenorphine.
Right. So talking about sublingual films and tablets, so when you see the slash, like the dose of 2/0.5, the buprenorphine is first. So you get 2 milligrams of bupe, you get 0.5 milligrams of naloxone. It comes in 2s, 4s, and 8s. I don't really ever see 12s. And the target dose for opioid use disorder is somewhere around 16 to 24 milligrams a day. 24 people do better on 24 milligrams. It's a state kind of policy whether folks stay at 16 or not. The question that comes up a lot with sublinguals is whether there is a max dosing. So we know that the opioid use disorder kind of effective treatment dose is 24 milligrams a day, but is that the actual max? And now in the addiction world, especially with potent non-prescribed opioids out there, people have been trying a lot higher dose of buprenorphine and being able to get that approved by insurance. And so there is no maximum to buprenorphine, just like there is no theoretical maximum to any other opioid. And I have had folks on 32 milligrams a day. I have heard of someone who's gone up to 48 milligrams a day to stabilize. This is for opioid use disorder and pain, and then bring him back down to like 24. So just so that you know, like if your patient's already on 24, it doesn't mean that you can't push the buprenorphine a little bit more at a higher dose. A couple of things to tell patients when they're using the sublingual or the buccal buprenorphine to make sure that they get the most effect out of it is that you have to let the film or the tablet dissolve completely. So keep it in your mouth for 15 minutes. Some of them have this orangey taste and some of them have a minty taste. And so if your patient doesn't like one formulation, you can try a different formulation. So going from films to tablets, going from generic to brand name to see if there's one that is a little bit more compatible with them. And then to make sure that you're not drinking or eating anything while you have that in your mouth, or in, I'd say like the 15 minutes after you have that in your mouth. Anything that is dissolved, or anything that is remaining after the medication dissolves, the patient can spit out. So they don't have to necessarily swallow all of their saliva. And remember, bupe isn't really active when it's swallowed. You just want that film or the tablet to dissolve so they can absorb the medication, and then they can spit out whatever is in there. And a lot of times, whatever's left is kind of gross tasting, a little bit bitter. So spit it out, totally fine. Avoid smoking kind of around the time that you're going to take your sublingual buprenorphine, and avoid using it with other medications. This is just that picture's in the wrong place. So just so that you know what's out there in kind of the comprehensive world of buprenorphine, or if your patient happens to be on it that you're seeing, these are less utilized in palliative care and in the pain world at this moment, but there's a lot of interest in it. So there are these sub-Q depots where you can, inject buprenorphine. It turns into a little ball, kind of like testosterone. It's super viscous. You inject it sub-Q, and then it slowly releases over the course of a month or a week. And you can actually get higher concentrations of buprenorphine with these injectables than 24 milligrams a day of buprenorphine. So is it a possibility that we might have some patients with chronic pain who would benefit from this at some point? certainly that's conceivable. And then Buprenorphine is that IV buprenorphine, just so that you know that's there. 0.3 milligrams IV buprenorphine is equivalent to 10 milligrams IV morphine in terms of opioid analgesia and respiratory sedation potential. So I know we spent a lot of time on these formulations, and I think that's important just because they can get so jumbled when you're thinking about what to use. And I really want to hone in back on the three I list here, but it's really the two that are the most useful. And up here I have increasing strength because I think of Butrans as low dose buprenorphine. So I have a patient who's starting out, somebody who's elderly, they're opioid naive. This is their first kind of trial of opioids. Butrans patch is what I would start. It is low dose. And then if they were titrating the patch and the pain is not getting under control, then what we'll do is we'll step up to sublingual buprenorphine, which I consider moderate to high dose. Really, it's high dose buprenorphine. Belbua is somewhere in between. It's kind of moderate dose. On the much lower doses, it's similar to the patch. And then on the higher doses, it's similar in effect to lower dose sublingual. So if you just have the patch and you have the sublingual, you can cover a wide range of buprenorphine dosing. And that's how I like to think about it, not so much as like what product it is, but how much buprenorphine is this patient going to benefit from, and then which of the products will help deliver that. So dental concerns is one thing we didn't talk about. You have the dental concern with the Bupe. They found that over time. And again, this is because buprenorphine is acidic. And so proper dental care, kind of rinsing out, seeing the dentist, et cetera, is important. And then just to point out the cost below, you can see that the buccal film, Belbua, is really, really expensive. This is from GoodRx, and I looked this up for like Palo Alto for, a month at the CVS. And so these are rough prices, but you can see that the patch is somewhere in the middle, and then the sublingual is the cheapest. So for this patient with, sensitivity to FOA side effects and who's going to start out on opioids, I would recommend starting him out on a transdermal formulation. 40 doesn't exist in the US, really. I would start him out at 5 and just see how it goes. If it doesn't work after 4 days, I'm quick to go up to 10, just because the 5 is, I don't know, it's really light. So I know we don't have that many minutes left. I wanted to see if there were any questions kind of at this point. Because from here on out for the rest of the session, but really the next session, we're going to dive into how you can use these formulations to really treat pain for someone who's on Bupe, treat pain for someone who's not on Bupe. And then it really feeds into what Grant was asking about later, which is how do you use the low dose initiation using these products? But we can do this one case. So this patient is a 45-year-old retired nurse, and she's a married mother of 4 kids with metastatic melanoma. She's getting cancer-directed therapy. She has OUD. It's in stable remission. She's on buprenorphine 8 milligram films 3 times a day. So essentially 24 milligrams of buprenorphine a day to treat the OUD. She's admitted with severe left arm pain, found to have an acute traumatic fracture. The pain is, excruciating. All the labs are normal. You're consulted for pain. What would you recommend to treat her acute pain? So she's taking the buprenorphine, 24 milligrams, kind of once daily. You split dose it into 2 or 3 times a day to treat this acute arm fracture pain. Do you increase the buprenorphine to beyond 3 films? Sorry, there's a typo. Do you stop the buprenorphine and start morphine as needed? Maybe you think that a full agonist would work better. Do you stop the buprenorphine, switch her to methadone because, methadone also is used to treat OUD? Or do you continue the buprenorphine and then you add morphine as needed on top of that? Great. So E, people are voting, and that's exactly what the recommendation would be. If someone's using 24 milligrams once a day You can split dose it and maybe get a little bit further with the analgesic effect, but it's not going to cover some acute severe pain like an arm fracture. You might use it for like a sprained ankle or something. So I do that a lot outpatient. I'll split the dose to try to get some additional opioid effect. But for a patient like this who's in acute pain from an arm fracture, you would add something on top of this to help with breakthrough pain. What I'm going to end with, I'm just going to leave so that we can start here the next time, is what breakthrough opioid do you use? Because that gets asked quite a bit. So if you have someone who's on buprenorphine, say at any, whether they're on the patch or whether they're on sublingual film, doesn't matter what you give them for breakthrough. And the answer is no. You can get any opioid to give the effect that you want. So you could give someone enough morphine or enough oxycodone where it will be more able to compete with the buprenorphine in their system. But a lot of times what folks will do if they have the ability to do so, or if they're inpatient and it's really easily accessible, and is to offer hydromorphone. And you'll see on this lipophilicity chart on the right that hydromorphone has, the most lipophilic nature, where it can compete the best with buprenorphine out of methadone, out of hydromorphone, morphine, and oxycodone. If someone's able to get fentanyl pushes like on the floor or whatever for breakthrough pain, that's great. That's going to work the most effectively. But that's really not, it doesn't have to be fentanyl or hydromorphone. You can use morphine, you can use oxycodone. You might just need to use higher doses or more frequent dosing to surmount the buprenorphine effect. Okay. Any questions? Oops.
It's like, Janet, we just got one question about special considerations for patients with kidney or liver failure when using Bupe. I think you maybe mentioned this earlier, but maybe just to reiterate kind of those considerations.
Yeah, so for patients with kidney failure and for those on dialysis, you don't need to make any modifications at all. For folks with liver failure or with some degree of hepatic failure, I would use the buprenorphine monoproduct, and that's because the naloxone is not metabolized as efficiently. And so as that builds up, you can have that exerting an effect and in undermining the analgesia. You would not use buprenorphine for somebody with decompensated liver failure or with Child-Pugh class C liver function.
Well, thank you so much, Janet, and everybody for coming to participate.